Welcome to HealthCode Blueprint, where we turn complex coding and documentation standards into clear, practical guidance. Today we're walking through a visual guide to UHDDS rules for additional diagnoses, what counts as clinically significant and how to apply these standards in inpatient settings. Disclosure: this presentation is for educational purposes only. It is not legal, compliance, or billing advice. Always follow official ICD-10-CM guidelines and organizational policies. With that in place, let's look at how UHDDS defines other diagnoses, how clinical significance is determined, and how to navigate key edge cases such as previous conditions, abnormal findings, and uncertain diagnoses at discharge. UHDDS Item 11b provides a very specific definition of what qualifies as an additional diagnosis. A condition must meet at least one of the following criteria: it coexists at the time of admission, it develops during the stay, or it affects the treatment received or the length of stay. Diagnoses from earlier episodes that have no bearing on the current hospitalization must be excluded entirely. For a condition to be reportable, it must impact patient care in a meaningful way. UHDDS outlines 5 pathways that establish clinical significance. The condition requires clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of stay, or increased nursing care or monitoring. If none of these elements are present, the condition does not meet the threshold for reporting. UHDDS definitions apply broadly across non-outpatient environments. This includes acute care short-term hospitals, long-term care hospitals, and psychiatric hospitals, as well as expanded settings such as home health agencies, rehabilitation facilities, nursing homes, and hospice services. Understanding this scope ensures coders apply UHDDS rules only where they are intended. When the alphabetic index and tabular list do not provide explicit coding direction, UHDDS guidelines step in. The provider's diagnostic listing remains the primary authority. 3 major edge cases require special attention: previous conditions, abnormal findings, and uncertain diagnoses. Guideline A clarifies that coders ordinarily report diagnoses included in the final diagnostic statement, such as the discharge summary. However, resolved conditions or status post-procedures from prior admissions must not be coded if they have no bearing on the current stay, unless hospital policy specifically requires them. There is an important exception under Guideline A. History codes from categories Z80-Z87 may be assigned when the historical condition directly impacts current care or when family history influences treatment decisions. These codes help capture clinically relevant background without misrepresenting active disease. Guideline B prohibits coding abnormal findings from labs, imaging, pathology, or other diagnostic tests unless the provider explicitly documents their clinical significance. This prevents coders from reporting raw data that has not been interpreted or validated by the provider. When an abnormal result is outside the normal range and the provider orders additional testing or treatment, a query is appropriate. This ensures the diagnostic statement accurately reflects conditions that are being evaluated or managed during the stay. If an uncertain diagnosis is documented at the time of discharge using terms such as probable, suspected, likely, possible, or consistent with, it must be coded as if it were established. This rule reflects the reality of inpatient diagnostic workups and the clinical reasoning behind treatment decisions. Guideline C applies only to inpatient admissions in short-term, acute care, long-term care, and psychiatric hospitals. It must not be applied in outpatient, home health, hospice, or other extended care settings. This matrix summarizes the UHDDS rules. Additional diagnoses must require evaluation, treatment, procedures, extended stay, or increased nursing care. Previous conditions are coded only when clinically relevant, abnormal findings require provider confirmation, and uncertain diagnoses at discharge are coded as established, but only in inpatient settings. This visual serves as a rapid decision tool for coders navigating complex documentation. Thank you for watching, and I'll see you in our next video.